So let's start talking about the thyroid. The thyroid impacts every cell in our bodies. There is a receptor for thyroid hormone on every cell. So the entire body is impacted in regards to symptoms. So let's start with the brain. Fatigue and brain fog, two leading symptoms of a low thyroid condition. Failure to lose weight because fat burning is inhibited. Insulin and blood sugar metabolism is also affected. It is much easier to become pre-diabetic when you have a low thyroid condition. Cholesterol numbers are also impacted. How well the gut moves, constipation, is related to low thyroid function. The gallbladder will even get sluggish and lead to a higher chance of having problems with gallstones. The stomach acid production can be impacted. Everything from anemia to hair growth can be impacted. Every other hormone in the body can be affected because all hormones interact with one another. Let's talk a little bit about thyroid hormone regulation. A tiny area in the brain, a very important tiny area in the brain called the hypothalamus, sends a signal to the pituitary gland. In response to this signal, the pituitary gland, which sits at the base of the brain, releases TSH, or thyroid stimulating hormone, in order to stimulate the thyroid gland to produce hormones. So the TSH, once it is received at the thyroid gland, will stimulate the thyroid gland to make thyroid hormones T3 and T4. So this process is regulated by the hypothalamus in the brain using the pituitary as the intermediary. And normally the thyroid follows the directions it gets from above. Every once in a while, the thyroid disregards the directions it's getting from above. So you have, in essence, mutiny. The thyroid gland no longer pays attention to the signals it's receiving from the hypothalamus and pituitary. So the thyroid basically does what it wants. These situations are clinically what we call autonomous function, where the thyroid gland is doing its own thing, regardless of what the brain and the pituitary gland are signaling. And these conditions can be difficult, but fortunately, the majority of patients do not have autonomous thyroid function, although it is certainly not an infrequent occurrence. And we see this in situations such as, obviously, toxicosis with Hashimoto's thyroiditis, what's called heshitoxicosis, as well as Graves' disease. There are also nodules that can be autonomous and do their own thing. So the situation of mutiny in the thyroid system creates a lot of problems, and that makes thyroid management difficult for some. So let's now presume that we don't have a mutiny situation and the thyroid hormones are being produced in response to TSH. 90% of the hormones that are produced are in the form of T4, 9% in the form of T3, and 1% in the form of something called reverse T3. Now, this T4 is like a precursor hormone, and in the body, it is converted into T3 and T4. We'll discuss this a bit more. So the T4 is really a precursor hormone. And reverse T3 is something that most physicians have not heard of, and I would say most patients have not heard of either. T3 and T4 are well-known hormones, but reverse T3, although it was identified in the 1970s, is little known about. So the T3, which is partially secreted from the thyroid gland and partially by activation of T4, sets the thermostat of our metabolism. So you can imagine if your thermostat is set too low in regards to your metabolism, you will not be able to lose weight, even though you starve yourself. So this T4 that's produced by the circulating, that's produced by the thyroid gland and is circulating around, okay, is activated into T3, because remember 90% of the output was T4. So what happens is the 4 means there are 4 iodine molecules, and when one of them is taken off of the ring on the side, it becomes T3. And the reason that is relevant is that if we remove a different iodine, okay, from the inner ring, okay, we create reverse T3. Now, reverse T3 is not similar to T3. In fact, it's like the opposite. It has absolutely no stimulatory effect. The increase in reverse T3 will actually slow down thyroid hormone effect. And this occurs especially during stress. Stress in the form of emotional stress, injury, illness, starvation, any of those instances. So if we don't look at reverse T3, we're going to miss what's going on with patients. And the standard of care does not address reverse T3. So reverse T3 can block T3. And I've put a whole host of references down there, not to overwhelm anybody, but just to let you know that what I am saying is highly substantiated in the medical literature. I am not making this stuff up. The effect of T3 can be blocked. So think about it, if in your car, your accelerator would be like your T3 and your brake would be the reverse T3. The balance between how much acceleration and braking you have is going to determine how fast the car goes. And similarly, the balance between your T3 and your reverse T3 is going to determine how fast your metabolism goes. Okay? So there is no controversy about this point. The T3 to reverse T3 balance is extremely critical, and the body very tightly controls how it will process the T4. Because remember, 90% of the output of the thyroid gland is in the form of T4. So the body has to regulate what it wants to do. Okay, so you're seeing T3, you see how the different iodine molecules missing? That is the only difference. So the conversion of T4 into T3 versus reverse T3 is going to determine how much thyroid function we have going on in the body. So this is the key means of regulating the thyroid function, is by the activation of T4 into T3 and reverse T3. And the ratio of T3 to reverse T3 appears to be the best indicator of thyroid hormone activity, not the TSH and not T. So how the activation of T4 proceeds is critical to how the thyroid function is going to be in the body. If there is elevated reverse T3, the medical literature indicates that there is definitely correlation with bad outcomes. Bad outcomes means things like death and disease. Reverse T3 as a blood test alone is not very sensitive. And so in order to really assess this activation of T4 properly, you have to look at a ratio between the T3 and the reverse T3. If this ratio is low, meaning T3 is low or reverse T3 is high, then there is going to be diminished thyroid hormone function. And this ratio is a far better indicator of thyroid hormone signaling than is TSH. So the ratio is far more significant than just looking at the reverse T3 number. So what is an optimal ratio, right? We want a certain ratio. The thyroid exit, when the hormones are made, we said was 90% T4, 9% T3, and 1% RT3. So roughly 10 to 1. So if we have a ratio of T3 to reverse T3 that is greater than 10, it suggests that we have good activation of T4 to T3. If this ratio is below 10, it implies that the T4 is not being activated, but instead is being deactivated into reverse T3. The ratio in healthy controls tends to be between 11 and 12.5. Our patients seem to do very well when the ratio is about 10 to 14. That's based on years of clinical practice. So our lab reports, they can actually tell us what the T3 is and what the reverse T3 is. And we have two different ways of measuring T3. We can look at a free, which means it's floating around, not tied to a protein in the blood, or the total, which means everything tied to proteins in the blood plus freely circulating. And we want to take a proper ratio, so we have to compare apples to apples. So we can't compare free T3, which is like an orange, to reverse T3, which is an apple. So we have to do total T3 to reverse T3, apple to apple. This will give us a proper ratio. So why all the fuss about the T3 and reverse T3? A lot of things will impact whether more T3 is present or more reverse T3 is present. In this diagram, you can see that T4 is being put out by the thyroid gland, and then it's being converted either into T3 or into reverse T3. Many things will impact this conversion. Things that will have a negative effect will tend to be stress, whether it's illness or emotional stress, toxins, including fluoride, pesticides, mercury, okay? Factors that also limit the activation of T4 into T3 are going to be nutritional deficiencies, such as selenium and zinc. And these are fairly common deficiencies, so they're going to impact. Even if your TSH is normal, if you are selenium deficient, you are not going to have an adequate amount of T3. You will still make reverse T3, but not T3. So as you can see, everything from exercise to toxins to stress to nutritional deficiencies are going to impact these ratios. And so ignoring them does the patient a disservice because we're not fully evaluating them. So why does the thyroid release a pre-hormone, T4, instead of active T3? A good analogy is it's for the same reason that Campbell's put soups in cans. Safe for transport, long shelf life, and you can open it when you need it. As simple as that.